Dear Chairman, dear ladies and gentlemen, before I start my presentation about erectile dysfunction in diabetic patients, I want to thank the International Hospital and especially Mr. and Mrs. Sierra for invitation. It's a great honor for me to be here. Today I will talk about urological complications of diabetes, such as the main complication like erectile dysfunction. In this slide you see there's about 20 to 60% prevalence in men with an odds ratio of 3 to 4.5. Another big problem in diabetes is the so-called lower urinary tract symptoms with a prevalence up to 40%, and in female the urinary incontinence up to 40%. Erectile dysfunction is defined as a more than 6 months persistent inability to achieve an erection for satisfactory sexual life. In talking to patients, it is better to refer to the symptoms as erection problems. Erectile dysfunction should not be confused with premature ejaculation, ejaculation delay, or the loss of libido. A penile erection requires a good neural transmission or proerectile impulse, an arterial blood flow supply, and a functional erectile tissue. A normal erection relies on a combination of psychogenic, hormonal, neurological, and vascular factors. These are broadly divided into psychogenic causes or organic causes. Here you see the multifactorial causes of ED, like drugs, vascular disorders, cardiovascular disease, and so on. About 70 to 80% of erectile dysfunction are due to organic growth. Approximately 20 to 30% have a psychogenic etiology where there are mixed forms and the initial cause is not always clear to clarify. The study by Steve shows the two most common causes of erectile dysfunction are due to organic diseases of the blood vessels and of diabetes. Problems in determining the prevalence is the problem of the man to tell the doctor to suffer from erection problems. Worldwide prevalence of ED is between 10 to 20%, and it's strongly correlated with aging. Among young men, 8% of the 20 to 30 years old patients and 11% of 30 to 40 years old patients experience erectile dysfunction. In over 70, it's about 70%. In this JAMA publication in 2005, you can see the correlation between age and the increased risk if the patient suffers from diabetes or hypertension. ED and cardiovascular disease share etiologies as well as pathophysiologies, and evidence suggests that the degree of ED correlates with severity of CVD. ED may be a predictive symptom for cardiovascular disease in otherwise asymptomatic patients, and ED may precede a cardiovascular event by much as 5 years in otherwise asymptomatic patients. 20 to 80% of men with diabetes suffer from ED, ranging from mild to complete and even with age. ED occurs earlier in diabetic patients, and the risk of ED increases if the diabetes is longer present and the condition is inadequately controlled. Sexual stimulation via the parasympathetic nervous system leads to increased blood flow and smooth muscle relaxation. This slide explains the neurological control of ED with the parasympathetic resting tone and the parasympathetic erection process and the sympathetic resting tone. Nitric oxide, NO, is the principal neurotransmitter in the erectile response. It activates an increase of cyclic CMP, which allows smooth muscle relaxation in the corpora cavernosa. In our daily assessment of patients suffering from ED, a number of standardized self-assessment methods is qualified ED are used. We use the International Index of Erectile Function, so-called EAF5. Every question can lead to 5 points, and it's summed up to 5 to 25 points. Another important tool to use is the erection hardness score with 4-point scale grading of the hardness of the erection. Here you see the EAF5 with the questions and the possible answers lead to a score of 25 maximum with a normal erection and lower than 7 with a severe erectile dysfunction. Here you see the erection hardness score, which correlates positively with erection functions from score 1, when the penis is larger but not hard, to score 4, when the penis is completely hard and fully rigid. For investigation, we do, of course, we do a physical examination. We do digital rectal examination of the prostate. We take a look at the external genitalia for miscarriages or birth defects. We check the blood pressure. We check the pulse intensity in the regions of the lower extremities. And we take a look at inflammatory changes. For blood testing, we take a hormonal status with serum testosterone, LH, FSH, prolactin, thyroid hormones. We check the blood glucose, cholesterol, liver enzymes, and we do an urinalysis. The diagnosis is divided into 3 steps. First step, non-invasive diagnostic. Second step, semi-invasive diagnostic. And the third step, the dynamic cavernosometry. First start with the non-invasive and most important diagnostic. It's a proprietary administration of PDE5 inhibitors like vardenafil, sildenafil, or tadalafil. This is even the first therapeutic step, and if the drug testing is successful, no further steps are needed. In PDE5 inhibitors are the different in clinical duration, clinical onset, and the Tmax. The side effects of these 3 drugs are nearly the same. An additional investigation is a measurement of the erection by this Rigi-scan system, where you measure the tumulus sense even during nighttime with spontaneous erection, and it's a good tool to validate the erection. The second step is a semi-invasive diagnostic by SCID testing. That means the SCID test is a pharmacological induction of a physiological erection, largely bypassing the neural stimulation by intracavernosus injection of prostaglandin E1, which leads to an erection. You can also use papaverine or phentolamine. Doppler or duplex sonography, in addition to SCID, can divide vascular from non-vascular regions from Idi by measuring the arterial blood flow after injection of prostaglandin. If we see a rapid onset with full erection, a vascular Idi is largely excluded. If we see a slow development and incomplete erection, there is an atrial perfusion disturbance. If anyhow an erection occurs, a relevant venous or cavernosus insufficient could be excluded. In contrast, MRI of the pelvis, you can visualize pathological vessels and arteriovenous shunts. Even this can be done with additional SCID injection. The last diagnostic tool is a dynamic and infusion cavernosometry and graphy, which is rarely used anymore because of MRI and high contrast. In this investigation, you infuse X-ray contrast and do simultaneous X-ray imaging, and you assess the venous outflow. Here you can see the pathological venous drainage. Now we come to the therapy of erectile dysfunction. First of all, it's important to treat the predisposition disease accurately, like adjusting diabetes, adjust the blood pressure, and quit smoking. Here you see a study from Fischer from 2002 who could show that intensive glycemic control can reduce but doesn't prevent ED. The known mechanisms of diabetes associated with erectile dysfunction are tissue fibrosis, defects on the NO-CMP pathway, and overimpression of ROA kinase and oxidative stress. A new hypothesis is the increased tissue-specific expression of ceruloplasmin, resulting in a pineal endothelial dysfunction. As a first-line treatment, the medication with PDE5 inhibitors is recommended if there are no contraindications. PDE5 inhibitors are vasodilators that work on the nitric oxide CMP mechanism to help restore natural erection function to prevent sexual stimulation. Sildenafil was the first licensed oral medication in 1998, followed by Levitra and Cialis by 2003. Here you can see the effect of different PDE5 inhibitors in patients with diabetes, where it seems that Levitra has the best result, but this was not statistically significant. Common side effects of PDE5 inhibitors are flush, headache, dizziness and orthostatic dysfunction, stuffy nose, visual disturbance, and heartburn. The concomitant use of PDE5 inhibitors and other NO donators is contraindicated. This is an alternative. There is a device to place prostaglandin E into the ureter, which should result in erection after 5 to 10 minutes. It's an alternative to the oral drug and works in some patients better. Another treatment option is a vacuum constriction device, where there is a rubber ring around the penis and then a vacuum is created to achieve an erection. A lot of patients don't like this because it's a very mechanical solution, but it works at the end. As second-line treatment, if oral drug administration is not successful, we use the intracavernosal injection therapy, the so-called SCID therapy, where prostaglandin is injected into the corpora. This relaxes the smooth muscle and leads to an erection after 5 to 15 minutes. Here you see the mechanism of action, like I explained before. The side effects could be priapism, that means prolonged irrigation for more than 4 hours, infection by the injection, hematomas, or plaque formation. Surgery is usually the last resort when other treatment options have failed or are contraindicated. We have surgical options like penile prothesis, arterial surgery, and venous surgery. Here you see the angiographical endocoiling by a V shunt, which leads to normal erection again. This is a semi-rigid inflatable penis prosthesis as we implant them as last option for treatment. The patient has control by pushing a pump next to his testis, which leads to an erection. To come to a summary, erectile dysfunction is defined as an inability to achieve and to maintain a penile erection sufficient for satisfactory sexual activity. ED appears to be more common as men get older, affecting approximately 52% of men aged 40 to 7 and nearly over 70% in men aged over 70. And the estimated prevalence in 2025 will be over 300 million men worldwide. A diagnostic tool we have EAF and EHS. We have to perform a physical examination and basic laboratory test. For treatment, we can use PDE5 inhibitors as first-line treatment, intracavernosal injection as second-line therapy, and surgery as last option. Thank you very much for your attention.